Hi, everyone. Welcome to another episode of Dr. Gilbert Hosts. Today, we're going to talk about a topic that many people want to know more about, but find very confusing, and that is genetic testing for Parkinson's disease. Now, luckily, my guest today is Dr. Roy Alcalay, and he's a world's expert on this topic, very adept at explaining the complexities of genetic testing to people with PD. So thank you for joining us. We're going to learn what exactly is genetic testing. We're going to talk about who should get it, what can be done with the results. And as always, we're going to answer your questions, so have them ready as well. And now I'd like to introduce my guest. Dr. Roy Alcalay is Chief of Movement Disorders at Tel Aviv Soratsky Medical Center in Tel Aviv, Israel. He moved from Columbia University, where he holds a part-time associate professorship there as well. Dr. Alcalay is a world expert on genetic testing in Parkinson's disease and obtained his medical degree from Tel Aviv University, Israel, his neurology training from Harvard University residency program at Mass General Hospital and Brigham and Women's Hospital in Boston, and his movement disorders training at Columbia University in New York City. He also earned a master's degree in biostatistics from Columbia University. His current research focuses on biomarkers and genetics in Parkinson's disease, and he's the principal investigator of the Parkinson's Foundation Initiative to provide access to genetic testing for the PD community called PD Generation. Thank you so much, Dr. Alcalay, for joining me.
Thank you for having me, Rebecca. Thank you for the kind words. I'm excited to talk to the group about the genetics of Parkinson's disease. And genetic testing specifically in Parkinson's disease, because this is basically making the research data that has been accumulated over the past 15 years available, more than 15 years, to the community. These are my disclosures. And as Rebecca mentioned, I moved a couple of years ago from Columbia University to Tel Aviv Soratsky Medical Center. And today I'm going to talk about the genetics of Parkinson's disease. I'm going to divide my talk to three components. First is I'm going to talk about the challenges in integrating genetic testing. Then I'll go further to like reasons why one would want to integrate genetic testing into the care of people with Parkinson's disease. And then the last part will be very practical of like how do you obtain the genetic testing. So starting with challenges in integrating genetic testing, I think the challenges actually start not with people with Parkinson's, but rather with the caregivers. So when we queried a cohort of people with Parkinson's disease who physicians who take care of people with Parkinson's disease, we realized that a lot of them don't test people and don't offer genetic testing to people with Parkinson's disease. So rarely people in the when we did the study in 2019, rarely was genetic testing offered to people with PD. And in that survey, only 41% of the clinicians didn't even offer genetic testing to a single patient, and over 80% of them to 10 patients or less. So if they offered it, it was for 10 patients or less. So it's really rarely, in the clinical practice, genetic testing is really rarely used. When we ask those clinicians to why do they not offer genetic testing in Parkinson's disease, you will see the response is that first of all, people thought that there's no insurance and coverage of the testing, and that would be an obstacle. The second point that the physicians made was that there was lack of perceived utility, like what's the point in testing? When we ask them about their knowledge, their comfort level in returning genetic results back, and we ask specifically about the two most common genes where they will have to return positive results back, GBA1 and LRRK2, I'll talk about them a little later, they scored themselves as 52 out of 100 in their level of knowledge of comfort in returning these results. So and this is a group of very educated clinicians who work in clinical trials in Parkinson's disease. So they themselves said, we're not trained, at least then, to return those results. And there's the next question of which genes to test, which seems trivial, but it's actually a very complicated question. So when a large group of clinical research was compiled into one study ran by Niles and colleagues in 2019, they found over 90 spots on the DNA that have been different in people with Parkinson's to people without Parkinson's. So there's quite a few spots on the DNA that have been associated with Parkinson's, but some of these associations are quite they're not very strong in the level of association, which means that based on that analysis, the risk for Parkinson's is 30% increased, which means that if the population risk is 1, the risk for Parkinson's for those who carry this variant is 1.3. So that's not a significant amount of risk, not enough to try to report this information back to people who are carriers. So which genes to test? We can go to what the clinical testing that is offered by commercial labs. So if the doctor prescribes the genetic testing in a commercial lab, what kind of tests will the participant get? And we saw that and this is the work we did with the University of Indiana, Lola Cook, we show that there's a quite wide range of options in what genetic testing the clinical commercial labs offer. And these are all very, very well-known, very well-established groups. And we see that if you send for the Parkinson's panel to Athena Diagnostics, you get 5 genes. And when you send it to Blueprint Genetics, you get 62 genes. And we put it in this kind of figure to the right to see that some of the genes repeat themselves in all panels, but some genes appear in some panels and not others. And that's for a large variety of reasons why a gene would appear in one commercial lab and not another. So in order to try to put it in order, we established a group that is called ClinGen that includes a very large consortium of geneticists, genetic counselors, people with Parkinson's, biochemists, to try to together try to get some kind of a consensus to when you call a Parkinson's related gene, what gene should be included. And as you can see from the logos, a lot of non-for-profits and the NIH have been working on it together. And together we established a panel of at least 7 genes. These are the first 7 that are most intuitive, that include alpha-synuclein, VPS35, which are dominant genes, so it's enough to get 1 copy to be at high risk for Parkinson's. Parkin, Park7, previously called DJ1, and PINK1, that are recessive, so you need a copy from mom and a copy from dad to develop Parkinson's disease. And LRRK2 and GBA, which are risk factors, so they increase the risk for Parkinson's, but most carriers of mutations in these genes will never develop Parkinson's disease. So with this data, 2 large studies went to people with Parkinson's and genotyped them. At the top, you will see data from the PD generation study, and at the bottom, which is primarily North American, primarily United States, and at the bottom you see a pie from the ROPAD study, which is primarily European, but there's also sites in the United States, Israel, and South America. You see that the results are pretty similar. Roughly 13 to 15% of people with Parkinson's, if they are genotyped for a panel of genes, are going to get a positive result. And the positive result, you can see in the right pie in the top on the top, primarily will be in one of those 2 genes. In orange, you can see it's the GBA, to be a carrier of GBA, or in yellowish orange, LRRK2. So this is like the majority of the people the majority of people who get genetically tested will get a negative report. Roughly 15% will get a positive report, which is a large minority. And of these 15%, the majority will be a result in either the gene GBA or GBA1 and the gene LRRK2. So if there is really, so now we show that the yield of returning results back is not that small, because there's so many people who get the results back. So what are the challenges in returning results? And when we started counseling people, we saw quite a few challenges. And one of them, as I said, is that the list of the genes to be returned is not something that everybody agrees upon. Like even between the ROPAD study and the PD generation, there's a big difference. ROPAD returns results about many more genes. The bottom line is that the positive number stays more or less the same, because the key genes are returned by both studies. People who develop GBA, people who get a report about GBA1, if you inherit a GBA1 mutation, abnormal copy from both mom and dad, one is at risk for the disease that is called Gaucher. Some people in the US call it Gaucher's disease. And it's a disease that because it can affect babies and children, for people who got prenatal genetic testing before getting pregnant or during pregnancy, this gene is being screened for. So when we give the genetic results back to, let's say, someone who is in the age where their children are already thinking of having children or are in the process of having children, there's implications in the genetic counseling that need to be conveyed, and that is specifically that one may want to get tested. Now, the problem is that not all the variants, not all the alterations in the GBA gene cause that increases the risk for Parkinson's also cause Gaucher disease. So the counselor needs to really know this gene GBA1 in and out. The genes that I saw that are recessive, that you need two copies, one from mom and one from dad, to develop Parkinson's disease, the most common of which is Parkin. A lot of the results that people receive from us in from the genetic tests is that they carry a single copy. What's the meaning of carrying a single copy? Is that a risk factor for Parkinson's or not? We still don't know, but we chose to return this result back just because if they're in the future, it will be more conclusively associated with Parkinson's disease, the people who got tested will have the results. And then the question that is always very concerning to people who get genetically tested is, okay, if now I'm a carrier, let's say of the LRRK2 gene, what is the risk of my children? And then this is a little bit tricky to tell because with most of these genes that I presented, it's not that if you have the gene, you'll have the disease. It's just a risk factor. Just like not all smokers will develop lung cancer, and not it's just a risk factor, and it's a risk factor that we can estimate how big the risk is, but we don't really know. The studies are very difficult, especially because a lot of time people develop Parkinson's in older age. And then when we ask about their parents to see what's the risk in the gene, the parents are no longer available for evaluation. So with this, we go back to, these are all the reasons why not to get tested, or what's the challenges in testing. And now let's focus on reasons to get tested. And really, I think that there's four major reasons why people may want to get genetically tested in Parkinson's. First is because genetic data may inform prognosis. So people may or may not want to know the prognosis, but someone has Parkinson's, they want to know, will I progress faster or slower? The genetics can help us. The second reason is that there are now clinical trials for precision medicine studies that target a single gene, and you can't participate in those trials if you don't know if you're a carrier. The third reason is that people say that Parkinson's is a disease that changed the quality of life, or changed a lot in Parkinson's course, and they want to know why they got it. So they just want to know. And then in people who are still in family planning stages, it's a little bit more straightforward why they want to get tested to see what's the risk for a potential offspring and what can be done to prevent it. So starting with clinical data may inform prognosis, just briefly, I mentioned those 7 genes. The genes that you inherit from both parents, the Parkin and the PINK1, people who carry those genes develop Parkinson's at a younger age, much younger age, sometimes the 20s or early 30s, but the progression is much slower. In contrast, people who carry mutations in alpha-synuclein and sometimes in GBA1, the Parkinson's looks like idiopathic PD. The typical physician cannot look at a patient and say, oh, you're a carrier, but where you look at them as a group and compare them to a group of non-carriers, their Parkinson's progresses a little bit faster. And LRRK2 is exactly the opposite. The Parkinson's looks like idiopathic PD, but progresses a little bit slower with less cognitive changes over the years when compared to people who are not carriers. The second reason that is to get tested, besides just the prognosis, is eligibility to participate in clinical trials. And that is really the beauty of the era we live in. For many years, Parkin, for example, was discovered in 1997, GBA and LRRK2 in 2004. For many years, the studies were observational. They looked at people with Parkinson's and they were saying, oh, carriers behave like this, non-carriers behave like that. But now in 2023, there are clinical trials that say, okay, if GBA1 increases the risk for Parkinson's, let's manipulate the pathway of GBA1 to slow down Parkinson's or maybe prevent it in the future. And the same for LRRK2. There's a study that was very well conducted, is going to be published next week by Genzyme Sanofi, that demonstrated that the drug they tried didn't succeed in reaching the goal of slowing down Parkinson's, but they were able to show that internationally they recruited 250 or more people with GBA mutations. Half of them got the drug, half of them got placebo. So it's unfortunately, the results are not as encouraging as one would have hoped. But the process of doing precision medicine clinical trials, of recruiting only people with a mutation and trying to manipulate the pathway of that mutation, this has already happened in GBA. There was another study in the Netherlands that is now being taken to a next phase in the United States. And in LRRK2, there are two mechanisms that have reached people with Parkinson's. One is oral medication that inhibit the enzyme that LRRK2 produces, and the other is injections to the spinal fluid of genetic material that would slow down the gene with hopefully less systemic side effects. So it's not only that one can participate in studies, one can choose which study to participate in. The third reason that I said that would be a good reason to get genetically tested is interest. Before I go about to talk about that, let me just say, so I think really, if you think about how we will treat Parkinson's in 10, 15, 20 years, hopefully people will look at us and say, what were they thinking? And ideally, people will come to the clinician with a clinical diagnosis that will be confirmed with biomarkers. The biomarkers can be imaging, like DAT scan, and also analyses of alpha-synuclein aggregation. So biological studies that will prove that the protein that is deposited in Parkinson's is present in their brain. And when they get that positive diagnosis, they will get genetic testing. If they're carriers, they won't just get the symptomatic treatment of dopamine-related medications, but rather if you have LRRK2, you'll get the LRRK2 drug. If you have the GBA, you'll get the GBA drug. And if you get alpha-synuclein or Parkin, the same. And people who are non-carriers will get a biomarker panel. And with that panel, we will be able to tailor their care. This is not today. This is a futuristic approach, but we're doing our best to get there. So the third reason that I said that people may want to get tested for Parkinson's is really interest and family planning. So in one of the genetic study that actually, also in the genetic study that I showed earlier, 23andMe, the direct-to-consumer company, donated or participated by sending 10,000 samples, which means that at least in the United States, at least in 2019, there were already 10,000 people with Parkinson's who wanted to know their genetics, had participated in 23andMe and received some genetic results back. As I'll show you, the results are not complete, but they're more data than they would have gotten if they didn't participate. So I hope that when you heard about those 4 reasons, you're somewhat convinced that there is a reason to get tested. And of course, people with family planning may want to get tested. But the next question is really how to obtain the genetic testing if one has Parkinson's. So there's a few options, and it's really all about availability, where one lives, and what is around. So there's the one option will be to get a clinical testing through a certified laboratory, and I showed earlier there's many labs. It can be direct-to-consumer testing that is available as I showed before, and it can be research protocols that I'll tell them a little bit more about them. So starting with clinical testing, as I showed you, there's multiple commercial labs. They offer different panels, and these panels are available for people with Parkinson's or their clinicians to test them. If one doesn't want clinical testing, that the results will get into the chart, and there may be cost to it, people participate in direct-to-consumer testing with 23andMe, and here you can see a couple of reports of people with who participated in 23andMe and got a positive result. It's a little bit hard to read. You'll have to trust me that even if it was in large fonts, it was hard to read. So that's why the FDA intervened and had 23andMe make the reports much simpler, and the reports are great now. But when you get tested through 23andMe, you get tested only for 2 genes, only for the GBA and LRRK2, and within the GBA and LRRK2, you get tested only to 2 variants. So, for example, when you get genetically tested for GBA in a commercial lab or in research lab, they test for 200 spots. In 23andMe, the result one would get back is only on 1 spot. It's the most common one in Ashkenazi Jews, N370S. As I said, in order to change this situation where there's genetic testing is not commercially available or really available to people with Parkinson's. The doctor don't send them. There are two research studies that launched. The first one is called ROPAD, the Rostock Parkinson's Disease Study. It's a collaboration between Centro Lab in Germany and Denali Therapeutics, multiple sites, and they already showed, as I showed before, the results. They've already recruited close to 20,000 people worldwide, mostly in Europe and a little bit in the United States. In the United States, the Parkinson's Foundation launched the study that is called PD Generation. The PD Generation initial role was to see whether people would want to do that. So when the study first started in 2019, a little bit before COVID, it wasn't clear whether the clinicians or the patients or people with Parkinson's would be interested. And then the question is, if they get the results back, what would people with Parkinson's do with the results? Will there be any impact? Will people get the results and say, hey, I want to participate in a trial, for example? And we wanted to, because we think that if we want to return the results back to thousands and thousands of people, we wanted to see whether we can do that through the clinicians or to do it through the genetic counselors, because one needs to establish a system to return results back to 50,000 people or so. So the PD Generation study, the initial study, the pilot, was completed. It showed the genetic testing delivered by clinician versus genetic counselor is equal. In effect, maybe patients prepared genetic testing by the clinician, by the clinicians, because it was a little bit more connected to the rest of the care. And as of 2023, there's over 10,000 people in the United States that have participated in the study, and the study is recruiting as much as possible. So I hope that I convinced you that genetic testing has shifted from an observational something that happened, that researchers do in a lab, to something that involves people's care. People may choose to participate in it. And to start a discussion, I'll end with a New Yorker slide where the patient is complaining to the doctor, and the doctor is telling him, I see, and have you tried worrying about it? So hopefully you understand now, or agree with me now, that with genetics, there's more to do than just worrying about it. But should genetic testing be offered, and how, is an open question. To try to answer this question with a Q&A, I invite Dr. Rebecca Gilbert to come back to the panel, and let's answer your questions.
Yeah, well, thank you so much, Dr. Alcalay. That was a lot of incredibly interesting information. I learned a lot. Thank you. And we already have lots of questions rolling in from our audience. So let's I'll try to keep them somewhat organized so that we can really have a conversation about genetic testing and how best to use it. So let's start with Nadalin's question, who asked a question that probably is on a lot of people's minds, which is that this person is the first one in his or her family to have Parkinson's disease, no other medical history. What are the implications for children in this situation when it's just the one-off? Doesn't seem like there's a whole family with it, just one person. What do you say? Is it worthwhile getting genetic testing? And is it different than if someone has a lot of family members?
Right. So in the PD Generation study, we broke down who got positive results to those with family history and those without. And basically, there's three groups of people who are more likely to get a positive result. Those with strong family history, those who develop Parkinson's at a young age, let's say before 40, and those who are of ancestries where we know that the genetic mutations are a little bit more prevalent, for example, Moroccans or Ashkenazi Jews. So if the positive result rate is roughly 12 in the overall study, it's above 15 in these groups, and it's 8 to 9% in those without any risk factors. So the person who was asking that question, if she's an isolated case, the chance that she's a carrier is roughly 8 to 9%. So it's not minimal.
Okay, excellent. And that actually helps us answer Diane's question, which is it possible to be diagnosed with PD and not have the genes linked to PD? The answer is yes, absolutely.
Right.
But looking for genetic testing is looking for this at least in a situation that Natalin has, is looking for 8 to 9%. So thank you, Diane, for your question as well.
And let me just
Yeah, go ahead.
answer Diana question. And so people who get negative result, how to interpret that? Because this is the majority or the vast majority of people, and it can be interpreted in one of two ways. One is that there's no genetic risk factor in that person, or two, there's no genetic risk factor that can be identified in 2023. But who knows? Science is constantly advancing, and please participate in research and help us identify more genes and more risk factors, because those genes that we discover are also future drug targets, right? So negative result may mean no genetics, or may mean we didn't find your genetics yet.
Excellent. Actually, that helps us answer another question that comes from Temple. So if we can get Temple's question up. And she asks, I have 58 known half-siblings, all from the same sperm donor. 4 of them have Parkinson's, but all of them have been told that there's no genetic component. Could a researcher use that family to find another gene?
Absolutely. And if you would like to contact me or the APDA, and they can forward me the information, I'm sure that there will be lots of geneticists that would love to communicate with you and hear more about the family and willingness to participate in studies. You raise, like, what you bring up is a great point, that in studies like PDGene and ROPAD, it's ethically inappropriate for us to ask people, did your family members participate, and what are their names, and where are they coming from? Because it's a challenge that if one family member lives in New York and another is in Kansas, I'm taking 2 highly recruiting sites for PD generation, we may not know that they're siblings until we analyze the DNA. So if you know of a family that has a strong family history, like in the case that you described, and there's no gene, this is really where there is a lot of effort put to identify more risk factors.
Excellent. So we have a series of questions that sort of all surround the same idea. So we've talked about somebody who has Parkinson's disease with or without a large family. We've talked about multiple family members who may not have a gene that comes up, and how to think about that. What about if you are a person who does not have Parkinson's disease, but you do have a family history of Parkinson's disease, and then you have a medical symptom that is making you concerned that Parkinson's disease may be in your future, like REM behavior sleep disorder or constipation? Do you think about genetic testing differently in that situation, where you may want to use genetic testing as another piece of information to help guide your thoughts about whether you're going to develop Parkinson's disease? What are your thoughts on that?
So first of all, I think it's a great question, and my short answer is there isn't a single answer for everyone. There are people who would say, really, I don't have Parkinson's now. The doctors don't offer me anything. I'd rather not know. And I think it's a very reasonable approach. And there are people who would say, knowledge is power. I want to know, and I want to get tested so I can further understand my risks. And that's a very reasonable approach. So I don't think that there's one answer fits all. And it's a question that each one of us, I don't know if I personally would have wanted to get tested in that situation, but I think it should be a person's choice and not the physician that says, oh, you shouldn't get tested. I will say that if you have a family member, if you're a family member of someone with Parkinson's, it's much more logical to first get the person with Parkinson's tested and then get tested yourself. Why? Because if you get tested and you get a negative result, you will not know if that negative result is reassuring or not. It will be reassuring if your family member with Parkinson's is positive and you're negative, which means you didn't get from them the risk factor. But if your family member with Parkinson's is negative, it means that we didn't discover the genetics in that person yet, or that there's no genetics, and then that negative result in you is much harder to interpret.
So you just answered Joanne's question. Thank you so much. She asked, so my dad has Parkinson's, should he get tested, or should I get tested? So
definitely start with your dad, and then when you get his results, think about it, whether you want to know or not. You'll have more time to think about it. The genetic counseling will be easier, and the yield of the test will be easier. Yeah.
Excellent. Just to let you know, we have a comment from Rosalind, who says, "Hi, Dr. Alcalay. Sid and I participated in a study back at Columbia with spinal tap. So good to see you're pursuing this work." So hello from someone from your past.
Yes, thank you.
So we have another question. Let's move into a kind of a new topic about how to get your doctor to get you genetic testing. We have a question from Bill Borden. If we are to advocate with our doctor to be tested, how would we do that? If we don't know anything, where should we start? What tests should we ask for, etc. if our doctor's not familiar with the options?
So I feel that if the doctor is not familiar with the options or is not comfortable with testing, then I would ask them if the doctor can refer you to someone who is familiar with the testing, because you want whoever is sending you to the test to be able to deliver the results in an accurate way. So not to over reassure you and not to frighten you with whatever the results show. For people whose doctors are not familiar with genetics, or some people are not being seen by a neurologist, they're seen by general practitioners for their Parkinson's, they can try to reach out to those studies online, to either the ROPAD study or PD generation, and there are online recruitments. They just so you see what it did to the studies. When the PD generation launched, our aim was to recruit 600 people in a year, and it took us, because of COVID, 13 months. And just in the month of February 2023, we recruited 732 people. So, and the major reason for it is the telemedicine. So you can log into a website, you read the information, you click that you want to participate, and someone from the study will reach out to you in due time.
Excellent. There are options if you are not connected with a physician who feels comfortable doing this testing. So that's fantastic. We have a great question from Denise, which is, and let's flesh it out just a little bit more. So Denise has had genetic testing, had a negative result. Would it make sense for her to advocate to get testing from a different lab that may have more genes tested? Because you gave so many different options. The different labs test for different things. If you've gotten testing from one of those labs, which have minimal genes, should you be advocating for your blood or saliva to be sent to a different lab to have more extensive testing? What are your thoughts on that?
So the answer is probably not. I mean, 30 genes sounds to me very comprehensive. I'm not sure that I can name 30 genes. They're definitely associated with Parkinson's, so it looks like a comprehensive panel. But to give a real scientifically accurate answer, I need to see which genes were included, get a little bit more family history and ancestry, because there are some mutations that are more common in different in people from different genetic backgrounds. Likely the answer is that you won't find anything new. But I will say another thing is that I don't know how old the test is, and good genetic labs should constantly recheck what they did a few years ago, because the data is constantly being updated. So one intermediate solution would be, instead of not testing or saying or getting tested with a new lab, is just to see if in the lab that already tested you, if they're reanalyzing the samples with new data or not.
Great, excellent. So we have a couple questions that talk about another issue that we haven't mentioned yet, and I'm not sure what your thoughts are on this. So both Michael and Cornelia ask a variation on the same thing. Does genetic testing become part of your medical history that you're required to reveal when you are applying for health insurance? Cornelia asks when you're applying for nursing home placement. So what do you have to do with that information in terms of privacy?
Right. So it depends how you did that. If you did it through 23andMe, this is something that you did recreationally, right? So it's not necessarily would be in the chart. It's your choice whether you tell your doctor. If you tell your doctor, it doesn't really matter where you did it, and they choose to put it in the charts, it's in the chart. PD generation and ROPAD are both research studies, so it's your and your doctor discretion to whether to put it in the chart or not. But I will say that there's a major difference, and that goes back to a previous question that was asked, between people with Parkinson's and family members. People with Parkinson's already have Parkinson's, so the fact that you also have LRRK2 or GBA shouldn't change much. If anything, maybe having LRRK2 means that your Parkinson's will progress more slowly. So I can't imagine how insurance companies or nursing homes or anyone would use that in a way that would be uh, challenging for the person who got tested. But if you are a person without Parkinson's and you get tested in a commercial lab and it gets into your chart that you're a carrier, I can see the potential for challenges with insurance there in a different way.
Okay.
And that's why also PD generation and DROPAD, they don't offer that to people at risk, because I think that requires more counseling about what is it you want to know, what is it you don't want to know, do you want it to be in your chart or not? Yeah.
Yeah. So we're sort of at the infancy of this, and we're going to have to flesh this out as a society more thoroughly. So we have a great question from Jermaine, a new topic entirely that we definitely need to address, which is the connection between the environment and genes. So Jermaine raises this issue. My dad had Parkinson's, and neighborhood kids, all 70 to 80, grew up on the same block. They all have Parkinson's, none have a family history. How does environment affect genes?
So there's a clear, very strong environmental factor in Parkinson's disease. And I think the best way to prove the importance of environment is the identical twin studies that have come out. So, for example, there is an identical twin study that came out of Sweden that showed that if your identical twin has Parkinson's, your risk for Parkinson's is roughly 12%. This is a humbling low number. I would have guessed 70, right? Your identical twin has Parkinson's. Even the environment is usually shared, right? And still the numbers are quite low. So even if they were wrong as many times as they were right, and it's not 12%, it's still 12.24, it's still a very low number. So first of all, absolutely the environment has a very important role. The problem with the environment is that it's so hard to study, right? Because the genetics is easy. We know what came first. Your gene came first, the Parkinson's came later. The environment, we don't know. Are we looking at environment in infancy, like were you breastfed versus cow milk, or are we looking in childhood? Did you have a lot of traumatic brain injury, like falls in the playground, which have been associated with Parkinson's in later age? Or is it when you're working and you're exposed to pesticides? And then we know that people with medical condition tend to remember better their history than people without, because so then when we try to look at pesticides, people with Parkinson's will remember the time they were sprayed by DDT, while the people without will just not remember it because it's not on the radar. So it's very hard to test the environment. We need better biomarkers for it. There are a couple of very interesting studies. There's a study by Virginia Rao at Columbia that follows kids, but from infancy, where they were exposed to pesticides that should not be used in urban cities anymore. And because of the association with Parkinson's and other neurological conditions, and they're now in their 20s, and they try to see whether the risk, even the risk that they had that happened in utero, does that affect their future risk for Parkinson's? We don't know yet.
Excellent. Yeah, lots that we don't know. We have a great question from Richard, which is, my mother had essential tremor and I have Parkinson's. Is there a genetic relationship between those two conditions?
It's a great question. The short answer is we're not sure. If you look at Medicare records or records like Medicare in other countries, you will see an association, and we don't know if it's a true association or if it's because some people were misdiagnosed as essential tremor or Parkinson's. Dr. Alan Lewis has dedicated his career to essential tremor, and a lot of the research between PD and ET. Probably there's a little bit of increased risk, but how significant is this increased risk? We don't know yet.
Great. So we have a question from Melissa, which we haven't addressed yet, which is, what about young onset Parkinson's? Do you want to think about that differently genetically if you have a family history or you yourself have early onset, young onset Parkinson's? Do you think about genetic testing differently?
So when we say young onset, we need to define young. So my definition of young onset is younger than me is young. But that's not a good scientific definition, and it constantly changes. So if we talk about young onset as very young, where people are still in family planning stages, then I would absolutely suggest not doing genetic testing through um, a research lab, and do it with formal genetic counseling to understand the implications about family planning. There are uh, advancements in the technologies in 2023 that can help that even if you have a genetic risk factor for Parkinson's, to see how it's not transferred to the next generation. So family, when we say young onset and we talk about family planning, definitely different type of counseling, the same genetic panel. And also it can be in very early onset. It's actually often reassuring, because if you have a gene that you need to inherit from both mom and dad, and you're trying to have a child with someone that doesn't carry the gene, then the risk for Parkinson's is very low in the offspring. And then in people younger age, my experience is that a lot of people with early onset want to know what caused Parkinson's at such a young age, and they're more likely to get tested than people at an elder age.
Okay, great. We are actually right at the end of our time together, which is kind of amazing. As I promised you, Dr. Alcalay, we had an extremely engaged audience with really excellent questions, one after the other. We're going to wrap up with one final question, which is on a number of people's minds. So, is there a difference if I do not have Parkinson's disease, or let's say I even do have Parkinson's disease? Is there a difference in whether I should consider genetic testing if I have a first degree relative who has Parkinson's disease in my family versus a second degree relative? Let's say I have a mother versus a first cousin. Do I think about whether I should get genetic testing differently in those two situations?
So this is, I think it's a great question to end with, because I think it goes back to what I was trying to say in the talk. I think previously we tested people based on the likelihood of getting a positive result. And I would actually recommend not to do that. I think we should decide, or people should decide, whether they want to get tested based on the impact on what will they do with the results. If you're someone who wants to participate in clinical trials, and if you find that you have a gene that may make you eligible for a trial that will be of cutting edge treatment, it doesn't matter if you have a first degree, second degree, or third degree, get tested. If you're someone that just sitting in a genetic counselor's room would make you freak out, you know that all you're going to get from it is worrying about it, then it doesn't matter if you have 4 family members with Parkinson's, don't get tested. I think the decision about getting tested is the impact. If you want to know why you had Parkinson's, get tested no matter what your family history is. You want to use genetic testing for family planning, get tested. If you want to know your prognosis and you want a little bit more information about it, get tested. But most importantly, if you want to participate in clinical trials and you want to know which one is for you, definitely get tested. If you feel like genetics is a little bit is mainly a source of stress, then don't get tested.
Excellent. Okay, I think that was a great synopsis and a great way to end. So I want to thank you so much, Dr. Alcalay, for all that fantastic information. I want to thank everybody participating today for their fantastic comments and questions. It really helped flesh out our conversation. Thank you so much. So if you know someone who missed today's program, if you joined late, if you'd like to watch again, this recording will be available later today on our YouTube channel. And don't forget to subscribe to APDA's YouTube channel to watch new videos and live broadcasts. For additional information and resources, please visit our website at apdaparkinson.org. Now, our next Dr. Gilbert host will take place on August 23rd at 3 p.m. Eastern Standard Time. We'll be talking about urinary dysfunction and Parkinson's disease with urologist Dr. Victor Nitti. So please register today and join us for that broadcast. Be sure to stick around for a few final messages. Before I go, I want to thank you and Dr. Alcalay again for joining us today. We hope to see you on another APDA program. Have a great afternoon.
Hi, I'm Leslie Chambers, the President and CEO of the American Parkinson Disease Association. Each month across the country, APDA is providing support groups, exercise classes, and educational programs like this one to support the Parkinson's disease community. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. If you enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Your gift can help APDA support people living with PD through local programs, reliable resources, and groundbreaking research designed to find treatments and ultimately the cure for Parkinson's disease. Please donate today at apdaparkinson.org/donate. And thank you so much for your support.